From the RSNA, welcome to Radiology Imaging Cancer Journal podcast hosted by Trainee Editorial Board. I am Yashvir Singh from Mayo Clinic. We wanted to highlight the ongoing special collection we have. Lacey and Pallavi are leading the pancreatic hepatobiliary collection with the help from Dr. Nariman on the interventional side. Dr. Iman Banerjee is an associate professor and scientific director of AI Innovation Hub at Mayo Clinic, Arizona, affiliated with Arizona State University. She earned her PhD in computer science from the University of Geneva, Italy. As a Marie Curie Fellow, her research focuses on multimodal data fusion, NLP for cancer registries, and fair AI development through model unlearning and adversarial debiasing. With more than 200 publication and H high index of 43, she leads multiple NIH funded projects. She serves on RSNA Radiology Informatics Committee and NIH Study Section, and as an editor board member on Journal of Biomedical Informatics and section editor of PLOS Digital Health. Welcome, Dr. Banerjee. Dr. Banerjee, your path is a global one, a PhD in a computer science from the University of Genova in Italy as a Marie Curie Fellow, and now Associate Professor and Scientific Director of AI Innovation Hub at Mayo Clinic, Arizona. What pulled you from your pure computer science towards healthcare AI? And was there a particular moment during your Marie Curie years in Italy that set a trajectory you are on today?
Yeah, that's a very interesting question because I think you probably don't know that I also did my master thesis in San, Switzerland, which was another very different domain. I was in a high performance computing in the Sun, and so I really liked the high performance computing as well as the core computer science questions like machine learning, pattern recognition, multimodal data analysis. But at that time, when I first started the PhD, AI was still at relatively very new, and the advancement was not same as what we have today. What changed for me was realizing that medicine produced one of the richest and most complex data ecosystem imaginable. Like you have imaging, clinical notes, genomics, 1D wave from data, pathology, longitudinal outcomes, all these things that kind of remain underutilized, because most of the time when we first started thinking about like building AI system, it was uniquely like unimodal. So ideally people are building radiology AI model, people who are building like ECG AI model, but they are not combining the data together. So that got me really interested because I was always interested in different types of multimodal data integration, representation learning, fusion. So that became like really interested. And then the first time when I was started working as a Marie Curie Fellow, it was a multi-scale project sponsored by European Commission. And we had a lot of hospitals working with us directly. But I was in a very applied mathematics lab, but there was a lot of hospital working with us directly. So I had opportunity to look and observe the doctors very closely, go to the surgery room, see the hand surgery and see how they are making the decision. And then it got me like so excited that how we can see the computer science method and technology directly being applied in clinical practice, and how we can really help the physician or surgeons or radiologists to completely change their workflow. And this kind of like incremental improvement, and I completely changed my career. Then I started doing the postdoc in Stanford again. Like I was in a very clinical plus computer science environment, and yeah, from there on, like I completely got caught up in healthcare.
Yeah, such an impressive journey. All over the world, you travel from India to Switzerland to Italy and now in US. So, leading an AI innovation hub inside one of the world's most respected medical institution is a very different role from being as an individual researcher. As a scientific director, how do you decide which problem are worth Mayo's attention, and how do you balance the pressure to sip working tools for the clinicians with the slower and deeper work of rigorous science?
Yeah, that is like really, really good question. That's we struggle every day, because sometimes the clinicians are working in so much in their domain. They think that one problem is like super important to be implemented now. But I honestly, when I take into a project into account, I always start differentiating what needs automation versus what needs a scientific discovery. When it needs just automation, it is not our job. Then we involve the IT people. Of course, we are kind of like working with them very closely to make even that automation work. But that is not our job. So what is our job is that if that automation needs a scientific discovery that is not available currently in the market or not available currently in the scientific domain, so that's why we work very closely with clinicians when they come to us with a problem, and we start working with that problem. And sometimes we see that that problem we already have some scientific solution, but that scientific solution can be even tuned up more to be suitable for that particular problem. And particularly what makes me so interesting to work in that kind of architecture is that we can carefully plan the validation, we can carefully plan the bias, reproducibility, and particularly at Mayo, we try to create a kind of middle ground where we kind of like combine the rapid prototyping with the rigorous prospective evaluation. That makes me so excited that we build the prototype, we immediately does a clinical translation with limited rollout, and we see that how the product is evolving every day. And finally after 1 year of like limited rollout, we see that the product completely changed from where it started, and that makes me so excited as a developer that it's kind of like see your child growing.
Yeah, I mean, like the listening your response is like the very, very well balanced in the clinical aspects, being as a computer science background researcher. So, like the wanted to know, like kind of the as I know that your work spans multi-model data fusion, NLP for the cancer registries, and fair AI development through techniques like the model unlearning and adversarial debiasing. The last piece, the fairness, is where a lot of healthcare is quietly struggling. Can you just walk us through what model unlearning and adversarial debiasing actually do in practice, and why do you believe that they matter more than the field currently acknowledges?
Right, right. So I think currently the whole field thinks that the data balancing is only solution for making an AI model fair for the different patient groups. But sometimes as a developer, we realize that we cannot get a balanced population always, because medicine is such a field that you always have the minority not in terms of race or ethnicity, minority in terms of age, minority in terms of their particular like disease, minority in terms of particular insurance or something like that. There will be always this kind of like a minority population in healthcare. So what we cannot do is that we cannot have always a balanced data that will represent all the patient population equally. And now if we bring that AI model to the actual clinical practice, we see that the model is drifting on that minority population. And it's not the problem of the model, it's the problem that the model have never seen that kind of patient population before. So particularly when we do limited rollout is much different than the commercial system. We always do a disclaimer saying that look, so we train the model with this kind of population, we know that the model is not going to work outside that, but still we want to be as inclusive as possible. So with that, we always put some kind of like a guardrail around the model development where we know that the data balancing is not an option. So adversarial debiasing is one strategy that we intentionally train a model to perform well on the clinical task while simultaneously minimizing its ability to infer the sensitive attributes. For example, it can be race, ethnicity, socioeconomic status, institutional origin, can be anything. So in simple terms, we try to force the model not to focus more on the medically relevant signal rather than the shortcuts or proxy. And which is very important because you probably heard this study, which was very famous during the COVID time, that the model was performing really well on the chest X-ray to identify COVID, but the model was particularly learning the proxy for the portable chest X-ray. And that time, portable chest X-ray was using for ICU. So, and COVID patient mostly were in ICU. The model was learning a shortcut, not learning any signal. So we just wanted to avoid that the model should not learn any proxy. But then also sometimes that proxy part is not easy to understand, because particularly when you train a center like Mayo, where we have multiple sites, we have Florida, Arizona, Rochester, with different practice, with different patient population, the advisory devices is not an easy solution either. Then we also go with model unlearning, that we discover while doing the limited rollout that the model has some privacy concern, the model has some demographic imbalance, model has some institutional drift. Then we start taking the model and the data where it fails during the prospective evaluation, and we try to do a model unlearning so that the model forgets those kind of like proxy behavior. Again, like, we sometimes do the both of these things, sometimes we do one of these things, but it depends on what kind of model and what kind of workflow we are considering.
So yeah, I am just loving your response because it's a kind of, I would say that's the you are speaking also very well balanced clinical language too, that like kind of the like kind of the computer science person or very technical person, they can correlate the response, and that like the how it is well balanced. So, coming to the next question, that as I know that the you sit in the seats that very few researchers occupy at once, the very prestigious RSNA Radiology Informatics Committee, and also you sit in the NIH study section. So from those vantage point, you see the field's submission before the public does. What patterns are you seeing nowadays in the healthcare AI, like healthcare AI research now, like kind of that excites you more?
If you ask me this question like last December, I would say that one of the exciting trend I'm seeing is that emergence of the multimodal foundation model, right? We have now multimodal foundation model that integrates the imaging text, laboratory data, genomics, longitudinal pattern. But starting from like this year, January, we see a completely different trend, right? Now everything is agentic AI. But I think one problem that I'm honestly facing, that, as you mentioned, like I sit in the study sections, I sit in the not only the NI study section, I also sit in like other federal study section, RSNA. I also am the section editor, like associate editor. What I'm seeing is that the people, particularly in healthcare, they are kind of struggling with this automation, and why it just need an automation versus why it's actually needs an agents. So we are kind of still struggling on that aspect. I think anything we can do to make sure that the people really understand that the difference between automation and agent, I think is needed. So I don't know if you know that, like, we actually created a course before with RSNA, it's the advanced AI, because it was a continuation of the previous AI courses. And I think that actually kind of clarifies a lot of questions that the people used to ask me when I go to RSNA, that, oh, what is this? Why we cannot do this? But now I think they start taking those like simple courses and understand that while we are struggling, I think now is the time that we do another kind of like a broad course on agentic AI, so that we grow that understanding, particularly within radiology.
Yeah, that would be kind of really good for like the especially new upcoming generation, and like and for the fellows and all that stuff. So like the I always ask this question to our guests. This is like I would say my favorite question. So if a donor handed you $1 million tomorrow with a one condition, that it could not go into the traditional research grant, but had to directly improve how AI serve patients in the community. Where would you put it? Like in a data infrastructure, in undeserved hospitals, or bias auditing tool, or clinician training, or patient facing transparency, or something else entirely?
Yeah, that's a very interesting question actually. Again, like, if you ask me again, like few months ago, I probably would really invest in the infrastructure, particularly on the unreserved healthcare system. But now I personally believe that we need some like really quick investment on the workflows development. But one thing I would kind of like not completely agree with you. The workflows development is not only the physician. We have to work very closely to do the workforce development for clinician, for technician, for nurses, for everyone. Because I think that now in this phase that we are working very closely with every different stairs within a healthcare system. But I think still being in Mayo, we are kind of fortunate because Mayo has a lot of resource for education at different stage, particularly with digital AI education programs. But I think what we are missing, particularly when we are going for the community hospitals or we are going for any other hospital, we are facing this problem that particularly the administrative people, the IT people who had to take that decision, that what kind of safeguard needed, what kind of infrastructure needed to make sure that they can adopt the AI. I think that education is still missing, you know. So I think particularly we have a responsibility to kind of fill that gap, and not only for physician, but at different stage in a healthcare system.
Yeah. So finally, what one piece of advice would you offer to the PhD students, postdocs, and fellows, and early career researcher, especially women's and international scholar who are navigating both computer science and medicine?
Yeah, that is also very interesting. That I so I so I usually suggest this to both physician side of them, like because I work with radiology residents, I work with MD students as well as computer science student because I have now like 7 PhD student, master student, undergraduate. I always suggest them that do not underestimate the value of interdisciplinary thinking. Because that language, as you also mentioned, right, that yeah, I can speak in both language, kind of do the balance, because it does not come in one day. It needs practice. You have to work very closely with clinician to understand their language. So even sometime now when they come up with a new project, I usually tell them that give me one day to read about it, just understand the field so that I can give you a solution. Because sometimes like they are so much domain specific that you don't know that what kind of problem actually they are facing. So for example, that Mayo, like in Mayo, some surgery team came to me with a plastic surgery problem. I have never worked on plastic surgery before. And when they started describing me the problem, I was completely lost that how I can really tackle that problem. So I told them that give me one day, let me read the literature, understand the language and what you are talking about. Then I can come back to you, and then it became so easier. That language, we kind of balance that language. So I think I think that when I talk with a computer science student, they usually believe that, oh, I know computer science, I don't need to know everything in medicine. That's true that you don't need to know everything in medicine, but the the project that you are working on, you have to know it. You have to know it start to end. So if that means that you have to sit with the clinician, understand the problem better, language better, or read the literature, do it and spend your time, understand the problem before you start attacking it.
Yeah, that is very important. If you are like trying to solve any clinical problem, so you have to understand what is exactly. Otherwise, like the model is running and we are like running the models and all that stuff, and that the output, if we cannot explain in a clinical language or like the clinicians are not understanding, then that is not any point of doing such kind of research. Then. So, well, thank you so much for today, and thanks for spending time with us today. A special thanks to our guest, Dr. Banerjee, for her valuable insight. And if you are enjoying the conversation, please rate, review, and subscribe wherever you are listening. Your interactions help more listeners find the show. Check out the Radiology Imaging Cancer link to the journal will be in the show notes. Today, you have heard from our team. Special thanks to our editor, Kelly Myers. We will see you next time on the Radiology Imaging Cancer podcast.